welcome back to the show. It's been a little bit of a break. Today we're going to deep dive into something directly impacting everybody, every healthcare organization. It's bottom line, and that's patient loyalty. Um, there's a mathematic component to it. There's a difference between patient experience and revenue cycle management. So we're going to dive into a little bit of all of that today. But first, I'm super thrilled to introduce my guest co-host today. Patti Consolver is a near and dear friend to me. We started off at Wilshire several years ago and then have broken away from them, other than I make Patti come back and do things with me through the podcast. She is the vice president of the front end of revenue cycle at Ascension Health, one of the nation's largest health systems. She brings a world of knowledge, 30 plus years in revenue cycle. She's a past NAHAM president. She has won multiple awards through them, including a fellow, and has been recognized by all of our peers in the industry as a leading expert in not only patient access, but all of revenue cycle and patient experience. So, Patti, thank you for joining us. Oh, and here's a big one to remember, everybody. She is on the Becker's Hospital Review as a female leader to know. So, we want to make sure that everybody knows Patti.
Wow, Evan, you have just really made me sound great. I love it. I love it. The last time I saw you was at the HFMA Western Conference. I think that was the last time we saw each other.
God, it's coming back up. So,
It really is. I'm excited. I'm excited. But that was a great conference too. It was a good conference. So yeah, we're gonna talk today about the patient experience equation. We've got how revenue cycle management directly impacts patient satisfaction and the net promoter scores. Oh my gosh. And to help us decode this math, we have Matt Lauer joining us. Matt is an MBA and certified patient experience professional who is an XM scientist for healthcare advisory services at Qualtrics. Boy, I'm glad you gave me all those kudos, Evan, because I'm going to be going up against an XM scientist. Matt, you have such a unique dual perspective. You've been both a patient experience leader at Barnes Jewish Hospital and you managed the family program at Ronald McDonald House. How did these two experiences shape your understanding of what patients and families truly need?
Yeah, well, and so thank you. Thank you for having me. This is
Yeah.
gonna be fun. But the number one thing is I want to say is like calling me an XM scientist makes me sound so much smarter than I am. So I just want to lower that bar just to I, you know, I know what I'm doing, but the last time I did a science experiment, it didn't go well. So, but
How do you become an XM scientist?
yeah, well, diversification of background apparently, and having
There
some
you go.
subject matter expertise in healthcare. Uh,
Love it.
One, but no, I think you know I've always kind of followed in my career that belief that one, you should be able to always put yourself outside your comfort zone, expand beyond your bounds a little bit, and always be challenging yourself, and always be open to opportunities when they present themselves to you. And so more than 20 years ago, if you had said I was going to work in healthcare or healthcare adjacent, I would have thought you were crazy. But, you kind of follow that path in life. And, at Ronald McDonald House, like I really went in with an opportunity to oversee the three houses and well, initially one of the houses in St. Louis, and then eventually all three of the houses that are in St. Louis. And you kind of step into an opportunity like that and think, you're going to be over brick and mortar, you're going to oversee volunteers, you're going to do all those pieces. But the beauty of that job is, we say Ronald McDonald House is the house that love built, and you get to be part of that system. You get to be exposed to these families. It was always my honor, and my privilege to be involved with them, both through the high times and their low times, right? Through the challenges and the struggles, and through a process of that, hearing about their experiences so often and what they were going on, not just with the health of their child, because folks that were coming to us, they were traveling from more than 50 miles away. They had a critically ill child, and so I was kind of living alongside of them, and was oftentimes welcome to be part of their journey. And you would hear about the frustrations they were having within the health system. And so when an opportunity at Barnes Jewish came along to be directly in the hospital, I knew that in order to be able to continue to honor those families that I met along the way, was to be able to go in and actually have some impact directly into that. And so, being able to bring those two experiences together has probably made me more well-rounded in patient experience overall because I'm always trying to look through the patient's eyes on what their experience is and what their expectation is, and helping enterprise health systems understand how to bring that all together.
Nice. I love that. And I love the fact that it's really that centric back. Like you're taking what you learned and reapplying it. I think we all think we're doing that, but being able to say, oh, here's that opportunity for me to now slide into that experience. I think that's so meaningful and that approach. What was that aha moment that you had that you realized patient experience was your calling based off of uh, what you just shared?
Yeah, I'm going to say it was two things. Number one is, um, like I said, I'm a constant believer in being able to grow and stretch and evolve beyond yourself, and I think healthcare needs to do that too. I think it always needs to be evolving to meet up with the generation of patients that they're seeing, and so that was part of that drive to go in there. But when you talk about an aha moment, like very personally, that aha moment, and unfortunately for a lot of the doctors I've worked with over the years, the bar was set by my child's pediatrician. My older son was born with Down syndrome, and so we were already having a lot of interactions with healthcare, and so a lot of the prism of those interactions were through her, through our experiences with her. But what told me I wanted to make sure I could change patient experience was when she cried with us when she had to tell us our son had type 1 diabetes, and to go on that journey. And so my level's always been very high, right? She's always been our biggest advocate. She's also been the one that's challenged us the most. Been the one that's been a great example of how to funnel empathy in a positive way to be like right in the shoes with you. Dr. Adrian Boise, who's our chief medical officer at Qualtrics, always talks about the importance of getting down in the muck with your patients. And like our pediatrician has done that with us and been with us for that entire journey. But we also had we had not great experiences. We've had frustrations with a lot of different parts of interacting with health system, whether it's, medication changes or, insurance interactions or interactions with providers or nurses that weren't always positive. And so I'm fortunate because I've had the experience in healthcare on how to navigate those things. So that aha moment is what do the people do that struggle with navigating through that, and how can we help improve that experience for them?
That's pretty cool. You feel their pain, and so yeah, you just want to be connected there. So like that scientist piece, you're also a certified patient experience professional. What exactly is that?
Yeah, so that's one of those things. It's twofold. So I always joke, the CPXP going through the process of getting the CPXP, number one, it teaches you a lot, and it teaches you stuff that maybe you don't always interact with in your role because it's so well-rounded and data analysis and patient experience and patient grievance processes and all those. But it's also important because it's a good demonstration within healthcare, that you know what you're talking about, right? It's a very intensive process to study for it. It's a very intensive test that you have to take. And it's an ongoing learning process. You have to do continuing education to maintain that designation. But for any PX professional, it's so important to be able to have that, particularly being able to show up. Like I don't know that if I was in any other profession, I would have a comma MBA, comma CPXP behind my name. Like I just don't know that I would. But in healthcare, we're so science and research based, and it's so important to be able to show up. I always show up with my authentic self, true and authentic self. But before you meet me, you also have to know that I've got this awareness and knowledge. And fun fact is that I love to help people who are studying for it, like talk them through the process because it helps keep me engaged in that as well. And and it just gives you that ability to, it kind of forces you to keep up with the changing world of patient experience, and it gives you a great opportunity to have an excuse to, go to conferences and learn, or go to the online training at the Barrel Institute and learn, and stay fresh and knowledgeable and learn from the, all the folks that are doing amazing things in patient
That
experience.
that's one of the questions I was going to ask was just, I mean, patient experience, it's so evolving. I mean, how often is it changing? I mean, is it like just every year there's something different, or I mean,
I wish it was every year. It feels like almost every day, maybe
yeah,
sometimes, right? Yeah, it's constantly evolving, and naturally, right? Like it's
right.
our experience and expectations with the way we interact with healthcare, it's going to change as people are interacting with it for the first time. And we've seen that and felt that and experienced it. Like COVID seems to be that table stake where we talk about everything before COVID and then everything after COVID.
Yeah,
It feels like it was
exactly.
light speed after, right? But like COVID opened us up to like, oh, I don't, if I've got something and I'm not feeling good, I don't necessarily have to go in and see my doctor. I can do it in this format, right? And that's required both ends. It's required our doctors who are great communicators, our providers who are great communicators, to learn that you have to communicate differently. You have to listen differently. You have to be more physically present when you're on camera. It's easy to feel like you're alone in the room, right? But you have to be able to have that feeling of like, how do I communicate differently in that space?
Yeah,
Um,
how do you still impact that experience when you're not there?
Yeah,
Yeah,
totally, yeah. And I think about, I was talking about this the other day, from where I live to the interstate is about 2.5 miles. And between my house and the interstate, you pass five different urgent cares and seven provider offices. And
right,
they're all from different, organizations.
right.
And so you're also in this hyper competitive space. And so you have to be able to meet the needs of these folks from coming all these different generations. And to be able to stay competitive, you have to be able to change to meet the needs of the folks that are showing up at your front door.
So based on that, and coming from an academic setting and then also other experiences working through, what are some of the big misconceptions that healthcare organizations have had around patient experience that you've seen?
Yeah. I think I think number one is they think that, especially as a patient experience leader in my past career, they think we're the warm fluffy, right? They feel like we're
Yeah.
the add-on, the nice to have that shows up at the door, and comes in and tells you like what you're doing wrong and those types of things. And I think that, over the last few years, this kind of human experience movement has kind of helped move that beyond where they were before. And I think we're able to show them that, really we can start to we can help them understand what the patients are telling them, right? For years, we've been asking for feedback, and then we've kind of struggled with, well, what do we do with that? How do we, what's within the locus of my control and what's beyond my control? And how do I balance those two things? And so, oftentimes, like it's even been portrayed on TV, right? That like, oh, we've got to keep patient experience high. We got to keep that satisfaction score, which drives me nuts. It's not satisfaction, it's experience. But keep those numbers high. And it's really, it's not a number. These are patients, these are people we're talking about, and we're inviting them to tell us how we did and how we can do better. And so I think that, the feeling is that we come in and we just kind of don't have any evidence-based practices to come in and say like, oh, you need to talk to your patients differently. But we do. And we don't always even have to just have the science. We just have that our patients are telling us this is what's bothering me and impacting me, right?
So you work with clinical, non-clinical departments. How do you get them to really understand that patient experience relates to their daily work, that they've got an impact on that patient experience?
Yeah, I think, I think number one, it's understanding the different personas that you are going to interact with and that you're sharing that data with, right? Because what is important to your chief marketing officer is going to be different to what's important to your CEO, your
Right.
chief medical officer, your CNO, your all you've got all of these different folks. And I think, number one is helping them align on we don't have to search for the answers, right? I think a good example is, I think we've talked for a long time in healthcare about access to care and what does access mean? What does it look like? And one of the things that I really try to do with organizations is say, like, let's not pretend we know what access means to our patients. Let's not just guess. Like, let's legitimately ask them, and let's listen outside of the walls of surveys. Let's try to make sure that we are capturing them at our digital front door, that we're capturing them when they're interacting with anybody within our teams, trying to schedule appointments, and really get at what access means to a patient, and then how you can drive those results across the organization, right? How it's gonna, how the investment in patient experience is gonna have a return on investment, because there are real solid numbers there.
It's
Um,
funny. It's funny you mentioned access to care because we've had a pretty lengthy conversation around access to care in my world because, like you said, there's different definitions around access to care and what that means. In my world, patient access services is that's what registration has been called for so many years, and now access to care is taken off in different other realms. It's you know entry in and strategic and different things. And so there's lots of areas that want to take over that access to care function. So it's like, okay, well, who owns access to care? And
right,
now you've got folks, having bidding wars over the naming and terminology of
right,
access to care. And it's like, golly, it's just a word, let's just get
right,
get get to the
yeah,
end, root of the problem. But it's
right,
like, how do you get to the end? And it's kind of like, okay, consumer experience or patient experience. It's just the
right.
terminology is just frustrating sometimes.
Yeah, and that's, I mean, I think that's like, it's on the nose, right? It is like, for the patient, if you ask them what access to care is,
I have
it's
no
going to
idea.
be availability to it. And maybe
Yeah.
for me, it's about being able to get an appointment when I want, and maybe for you, it's about getting the appointment where I want it.
Yeah.
And so how do we balance those two,
Yeah.
right? And often, like, internally, right, when we had those same conversations. Like, when we talk about patient access, we're talking about all the folks that are sitting at the registration desk to get you in the door, but the patient isn't even thinking of that, right? They're thinking of, that's just the registration person I have to go to. Maybe you talk about money, maybe not, I don't know. But if that experience, like, I think we always thought in the eyes of, like, toes in to toes out, right? That the experience starts when they show up at patient access and when they're done with registration. But we are seeing that evolve to know, like, the second somebody realizes they need healthcare, that's the moment their experience starts. Because if they can't even find your website, or they can't find a way to get to you, you've already had a broken experience, and that's what we're trying to solve for, right?
Yeah. No, absolutely. I think the other element of we're having this debate too of like what falls into revenue cycle and who controls, my organization, we're an on-demand primary care group. And what does that actually mean? Like, as we're now primary care. So, versus being seen in the light of, oh, you're just an urgent care. Well, no, we can do that, but really it's our mindset of access to care is care when the patient wants the care, right? And where in an available location nearby. So I think everybody, even as an industry, we're all going to define it a little bit different as we go.
Right, right, absolutely.
Well, let's take a quick break and we'll be right back.
There are thousands of medical offices and facilities across America, each navigating through changing regulations and reimbursement models while striving for positive patient experiences and outcomes. A common element in each of these facilities is patient access, the front line of both the revenue cycle and the patient experience. Though diverse in facility size and geography, patient access professionals unite around a common purpose: enhancing the overall patient experience to increase patient satisfaction and outcomes. Through it all, one organization is there to educate, connect, inform, and pave the way toward the future of patient access. The National Association of Healthcare Access Management recognizes the changing role of patient access professionals and their increased importance.
And we're back. Well, now that we're back, let's continue this deep dive. What are healthcare organizations getting wrong when collecting patient data?
Yeah, that's a great question. I don't know anybody's getting it wrong, right? I think everybody's working through the resources that they have. I think the way we need to approach it is like, how can we think about it different? How can we approach it in a way that we're kind of getting that more well-rounded view of the experience? Traditionally, we've really focused on that small space of post-transaction care, right? Like you've gotten your care and we send you a survey, and that's what we've relied on. And kind of within that theme of the way things are evolving, it's harder now to break through the email wall, right? We went from, hey, we're going to use paper or phone to, oh, now we're going to start emailing and use SMS. But every day those restrictions are getting tighter. Our inboxes are getting fuller, and it's getting harder to reach the patient that way. And we know that we're kind of hitting them at a point where, we're only hearing one part of the story, or we're hearing a part of their story when they give us feedback about a different experience they had. And that can sometimes cause you to say, if I go to my doctor and it was because I had been at the emergency department a week before and my experience wasn't good there, but my survey comes from my doctor, I'm going to tell them about all those experiences. And so I think what it really needs to come to is that we need to start to break down some silos. I think, Patty, you had like a great conversation before, like, who owns what part of this? And so often, and myself too, right? In the patient experience world, as a patient experience director or leader, you're very focused on that PX improvement, but you're not always focused on brand reputation. You're not always focused on revenue cycle. You're just focused on those pieces. But there are people that are focused on other parts of that. And so we're doing a better job of getting feedback along more points of the journey where we have that opportunity to improve, and where, like where we've seen a lot of success with clients is starting to tie those dots together and be able to pull that string of the story. Where are we having service breakdowns? Where is there a bottleneck? And then what's that impact along the way? Right? So having more ownership, like that previous example, if I have a bad experience in an ED at a healthcare organization, and I go see my doctor at that same healthcare organization, if everybody owns that there was an issue because it was that same healthcare organization, the better off we'll be. And if we have better insights and we could start to predict, hey, this is where it's breaking down. And maybe was there a reason that we could have prevented me from having to go to the emergency department, and I would have had other options to access care, not to bring that back up, but other options to get there, right? Then maybe I can move around that and move beyond that a little bit. And then I think the other big thing is, something I talk to like every client about, is democratizing that data. Get it to the hands of your leaders and be very open about it. Get it into anybody that wants to look at the data. You should be giving it to them. Let them see what's going on within the organization, and not just sometimes in their own realm of their control, but let them look and see what's going on in the rest of the organization. And we in healthcare, we're all problem solvers, like sometimes almost to like a fault, right? Like we want to
Yeah.
fix things, but sometimes the answers are with our peers and we can go out and see those pieces. So I think really being able to say, I can have access to my data, but I can see what's going on in the rest of the organization, and trusting our leaders and our frontline team members to be engaged and maybe bring some solutions that are going to help.
Yeah,
Yeah,
it's
that makes
interesting
sense.
that you say that too, because I step back and I tell, and Patty and I've had this conversation in many of our interactions when we were consulting together of Rev cycle can make or break the true patient experience. So having us engaged as part of the planning and the communications and what are those key questions is really key, because it's not just the point of I'm seeing a registrar and I'm getting registered. I'm also going, if like we end up sending in bad debt collections, that experience can still have a positive experience with the patient. It doesn't have to be a negative outcome. And I think that is something I know culturally we're having to make some of those shifts still in the industry today of bring us to the table, not just the providers.
Right.
Yeah.
And
Yeah. I was just going to say, when Evan sent me the information when he first told me we were going to be talking, I was looking at the your bio, and it says there's a little blurb that I was interested in. It said, more fully utilize the insights gathered from patients and care team members. What does that mean in practice? You know what I mean? What's the gap between data collection and actual improvement?
yeah, the the big thing there is, and I kind of smile and laugh because when I was at Barnes Jewish, my process was I had the weekly report that generated Sunday night, so that when Monday I'd get in the office, I'd have all of the patient comments that were submitted for everywhere within the hospital, and I would
Wow.
see
Yeah.
those on Monday morning, and I literally was going through with a highlighter, and kind of trying to highlight things and figure things out, and where do we need to follow up, and a couple of things that like popped up to me was like, I would be highlighting things that it's like this should have been caught. Like these are like if we were communicating well, this should have been caught, or this was preventable. This is a patient I want to talk to, and I think when we talk about like better utilizing the data, like there's no reason, especially now, right, with the ability of AI to be able to go in and tell me where I need to be focusing and what topics are coming up. And I'm going to tell you, like, I never tell anybody not to read all their comments, like they should be reading them. But better utilizing them is not having to go through and highlight them and try to figure out where the topics are that are bubbling up, but putting it right in front of them. There are mechanisms that will bubble up those patients that need to be reached out to, who just want to just want to be heard. The number of times I called patients and they, at the end of the day, like they understand we can't fix what happened in the past, but just the fact that somebody picked up a phone and called them, like
Yeah.
surprise and delight, right? Like that is the definition of surprise and delight is, wow, this guy picked up the phone and took 15 minutes to just hear my story. And maybe sometimes we could do something or help them out, and sometimes they just knew like there's nothing you can really do about this. But I could reassure them that part of our role was to fix those things. And so if we can use the data in a way that speeds up that process, if we can use the data that gives us an opportunity to fail fast, right?
Yeah.
It goes back to democratizing the data. If I'm a nurse leader on an inpatient unit, or I'm a practice manager, and we are putting in an intervention to fix a metric or to address a service failure, I want to know if it's going to have the wrong effect tomorrow, not 2 weeks from tomorrow, or that I have to dig for it and I'm missing it. And so, that's part of what we try to do with clients is help them really get beyond the structured data and be able to dig into their unstructured data and like pull up and help support why numbers are going one way or another, right? Those are just indicators of feelings of patients, but their truth is in what they're taking the time to tell us.
So, Matt, you've mentioned what you guys are doing in your organization at Qualtrics. What really drove you or drew you to come to them versus other patient experience organizations?
Yeah, when like funny enough, when I came to Qualtrics, I don't know that I don't know that I was looking for that change in my career when the opportunity initially arose, right? And but as I said early on, I've always looked at every offering as an opportunity, and you investigate. And the number one thing that drew me in was, organizationally, through our interview process, it was very clear that the values that they are plastering on their website are very true. Everybody was very engaged in wanting to meet with me, talk to me. None of the interviews felt like an interview. They felt like conversations, and a lot of times it was like I felt like I was talking to my people, right? Like this was an opportunity to do something different. But what I also liked was that a lot of the stuff that I was trying to do in my own career, maybe sometimes was even struggling with making that forward momentum, Qualtrics was all in on. They were all in on wholesale culture change. They were all in on how do we look at patient experience differently? How do we impact it differently? And how do we demonstrate that we can drive value and we can drive action based off of the information we're getting from the patients? And so, like, that excited me, right? Then once I got into the organization, like, it was, they were walking the talk without a doubt. And for me, I had had a great opportunity at Barnes Jewish to really help shape the culture and patient experience there. And I was making a dent in healthcare by being at Barnes Jewish. Um, the opportunity that was at my hands was to take everything I've learned and be able to start to learn from other organizations and be able to say, you know what, I'm having an impact now on a lot of different healthcare organizations. I'm able to bring with me that ability to say, you know, this is how we can improve the human experience, period. And the other piece of that is the expertise that goes beyond healthcare that we're able to draw from here. We're able to learn from what's going on in the rest of the XM market and be able to help adopt some of those into healthcare. But also, funny enough, we're doing a lot of things right in healthcare. And so we are also having this cascade effect on the rest of the XM industry as well, right? There are things that we do well in healthcare that we've kind of sort of started to figure out, partly because we have an understanding that we're dealing with humans. And so, our product is experience. Our product is healthcare, but you have to have those human interactions to go in there. And so we've been able to help teach a lot. So it's gone both directions for sure.
So for those healthcare leaders that are used to the traditional patient satisfaction surveys, how does Qualtrics differ from those? I mean, how does it make it what is the difference?
Yeah, I think where we differentiate is a lot of what we've talked about. So we want to make sure that we're leveraging the data in a way that is really able to be able to drive tangible actions. I think a lot of times in healthcare, what we've been able to do in the past was rely on the tried and true measures for experience improvement, right? We know in the inpatient space, right, that there are true ways to drive and change the experience, but how do you keep those sustainable and how do you continue to change based off of the feedback you're getting? And so, what we can do differently is number one, we have a lot of flexibility within the platform and we can start to drive that story that we can, if we're making changes, we can also make changes in the way we're interacting with the patients and requesting their feedback. We have a connected end-to-end process to be able to say, pull in data from a lot of different sources and be able to say, what is this impact? What is this impact across the entire enterprise? So not just one hospital, not just one unit, but what are these, trickle down effects from a patient's experience across the board? And how can we track them through healthcare to be able to make sure that we're creating that frictionless experience for them across the board? But then also the flexibility within the program to be able to make sure that the data is getting to leaders or frontline team members in a way that's digestible for them. We've really started to come in, and I think I touched on it a little bit ago. Being able to leverage AI to give you a headline at the beginning of your day to be able to say, hey, this is what's going on in your data. Particularly, I always like to say, like in healthcare, we have some of the most highly educated folks in the industry working within healthcare. But you literally can be a nurse today, a staff nurse today, and a nurse manager tomorrow. And there's a lot of stuff you have to learn on the fly. And so the more we can put into your hands to help you make it understandable and fit it into the finite amount of time you have in your day, that's what we're trying to aim for. Because if you know exactly what's going on in your unit, you can drive that change. If you know exactly what's going on in your practice, you can drive that change and you can see the real impact. And for us, for me, for our organization, the biggest key is, we've in healthcare, we've often kind of put the carrot at the end of the stick and said, like, hey, this is where we're marching for. And what we want to do is really, do away with the stick and give the carrot, right? And be able to say, like, hey, here are opportunities now. Like, let's help you identify opportunities to recognize your team. Let's make it easier to put the recognition in their hands. We do some of that through partnership with Daisy Award and being able to like expedite those processes. But we're also being able to do that by just being able to leverage the insights of when a patient names one of your team members, and it makes it easier to pinpoint that. And being innovative in ways to like put recognition tools right in there, so a leader doesn't have to go outside a dashboard to have to be able to make those recognitions.
I think the hardest part, though, for like a revenue cycle leader is we're so used to metrics and having goals. And I'm sure you hear this all the time from, revenue cycle. It's, well, what's our goal? What are we supposed to be aiming towards?
Right.
And, that's a frustration for us. It's like, well, what are we supposed to be working towards? Because we'll work towards it. Give us a goal and we'll get there. And it doesn't seem like we have an industry best practice in different areas. Why? Where's that?
Yeah. So, I think it's an interesting conundrum, and goals are never going to go away from us. As much as we may struggle, like we always do have to strive for improvement. It's the only way we're doing something right. Um, and I think that the difference is that like that's what we're always grasping for is like what's that silver bullet to drive that improvement. What do we need to do to get there? And the beauty is that we don't have to, like, I can come on, that's part of my job, right? As a subject matter expert is to come on and partner with clients and talk about what are the 5 things we can do to improve. But a lot of the times I point back to, but it's right there in front of you. Like, let's start to dig in and really see, like if you are listening, if you're listening to phone calls and you're taking those transcripts, you can start to plug that in to a tool like Discover, and it's going to start to tell you like, here are your opportunities to improve this. This is where things slow down. This is where things get rough for patients. This is where, these are terms that are popping up around frustration. It's the same on your digital front door, right? If you start to rage click, we can pop something up that says, hey, what's broken? And so the goal is not to have to grasp for what are those best practices that are out there. Like true life example from my own experience. I was on a part of a team, we're really good with tiger teams in healthcare, right? But we were on this team to go out and look at what are the best practices that everybody else is doing to help drive communication. And we were a few months into this when somebody, the nurse scientist that was working with us, said, hey, why are we looking everywhere else? Let's just start right here at home and let's just look across individual spaces and see who's got good scores. Let's go observe them and see what they're doing. And what we learned is the ones that had the best scores were the ones that were adapting very quickly to the issues that were, within their unit and within their clinic. And then we realized, like, oh, they're doing some of the best practices. Like, nurse leader over here is doing monthly trainings with her team on proper communication during hourly rounding. And so that was like we've always said, like we know that hourly rounding will increase in inpatient, scores, communication scores. It decreases infections, it decreases falls. But she had figured out, you know what, monthly, I got to go back and do a refresher on that because if I'm not doing it, I'm not holding myself accountable to it. I'm not holding them accountable to it. And so, I think that's a big part of that too.
I mean, it definitely sounds like you're taking it beyond just the mathematics behind it, but is there a mathematic component with it as well? We know in the traditional world, you would get fours, fives, ones through fives, and then you would focus in on reading the ones and twos because that's where you're looking for the improvement, and you weigh out the fours and fives because you're kind of in that 1 through 3 range. Like, what's the additional science or mathematical component behind the approach?
Yeah, the big thing is that, we still do have to listen to those folks that, so many of our clients use NPS, Net Promoter Score, as like that key metric, right? And so you do have to listen to those folks that are giving you the 0 through 6s, those detractors, because that is typically where the service failures are happening. But the other piece to that too is that, they're when, Patty, you talked about goals, like being able to set goals is really trying to, like, if you can shift to that focus of looking at what your internal performance has been, where you've been in the past, where you are now, and where you have the capacity to go, and really being able to say to teams, you know what, we're gonna set a goal for the organization, but you should also know this is where your individual goal can head. This is where you've had the capacity to grow. And if you grow, this is the impact you're having on the organizational goal. Like, so often they feel so far away, right? When we say our organization wants to be at an NPS that's in the 90th percentile, and how do I control that in my space? If I have a better idea of knowing where that is, then at least I have some North Star that I can kind of say, okay, this is what's within my control, and I'm not going to drive, I'm not going to go too far outside the rails, or I'm not going to pull the score down if I do X, Y, or Z. But there is also opportunity in when you are gathering that information from folks that are 0 to 6s, or you're gathering information from folks that are 7 to 8s. If those are the folks you're closing the loop with, right? That inner loop process of service recovery, it can't stop there. When we talk to patients, when we call them, when we reach out to them, and we learn about where their service failure was, now we have a whole new set of treasured information that we can kind of take to that outer loop piece side and say, okay, like, it's really easy for me as the clinic manager to get lost into every phone call that I've made and listen to those pieces that are going on, and this is what was broken. It's bigger if we can take all of that together and say, okay, let's stop looking at the individual piece that's broken, but what's the root cause of some of this, right? Is it our scheduling issue? Is it lack of transportation? Is it, patients are in a space that the healthcare, we're taking them for granted because we might be the only one in that space. Those types of things we can look at from an outer loop focus, and then start to put together action plans to try to fix those process problems so that we stop having to make these phone calls and maybe spend more time on the folks who are giving us the 9s and 10s, which does go back to giving the carrots too, right? Like, we can also focus on that and help our team members know where they're doing well.
I kind of see where you're going with that, because, like, just for example, we'll use the 5s and we subtract the 3s, 2s, and 1s, and we don't use the 4s at all. But I may have a high number of 4s, but we're not using those. But so behind the scenes, what I'll do is I'll look at those 4s, and I'll look to see, okay, are my 4s moving to 5? Because the more that's happening, I want that to happen. But if my 1s, 2s, and 3s are moving to 4s, that's a good thing too.
Right.
And so I want to watch that. So I still want to track that.
Yeah. And that's kind of that beauty of the net scoring system, right? It can be a pretty volatile number in the sense that, it takes that focus off of, I think, like, so often when you focus on a top box score, the focus is, how do I get everybody to a 5, right? Or how do I get everybody to a 10? But that net score kind of says, like, it's a win to get people out of those bottom scoring ranges and into a 4 or into the middle, right?
I think it's just as important to look at those bottom 3 going into the 4s.
Right. And then so it adds that piece to it. It gives you that feeling, like, that's kind of like the beauty of the net promoter system, right? Because if you can move them into 7s and 8s, like, that's a win, because maybe you've recovered a relationship that you would have lost otherwise, and you're not ignoring that middle space, right? But you are also celebrating the win that you didn't have to move somebody from a 0 to a 10 or a 1 to a 5, you got them moved along the spectrum in the right direction. And you can take that as a win.
You've mentioned like 7 and 8s and 4s and 5s and net promoter scores and NPS and net scores. What is the difference between all of that? What's the difference between a net promoter score and a net score and the 1 to 10 scale and the 1 to 5 scale?
Yeah.
That's all kind of confusing.
Yeah, so Net Promoter Score is a concept developed by Bain that really says, they've, the shortened version of it is they did a lot of study and they realized that 0 to 10 is a scale that people recognize the most, right? It's the one that's very recognizable. And through their study, what they determined was is folks that rate you a 0 to 6, and Net Promoter Score is a likelihood to recommend. So basically, it's saying based on your experience with this medical clinic or this provider, how likely are you to recommend their services to your friends and family? It's a big, powerful piece, right? And so folks that fall within 0 to 6, those are the folks that are going to be your active detractors. They're going to tell you about the bad experiences they had. The 9s and 10s are going to tell you about the good experiences they had. And so those folks that fall in the middle, they're passives, right? They may be lukewarm on it. They may be people that are never going to give you a 10. They're pretty, copacetic in the space they're in, and that's okay. But the thought behind that is if Patty comes to me and asks about my experience with an organization, and my experience was a 10, and I'm going to tell her about how great it was, and then she's going to go talk to Evan, and Evan's going to have had a bad experience, and he's going to tell you how bad it was, you're going to be stuck somewhere in the middle. We cancel each other out. And that's kind of where that focus is. And so the net score for lower, for 1 to 5 ranges, 0 to 10 is pretty good for a top line metric, likelihood to recommend. But you want to be able to be bipolar in the way you're asking questions below that. It gives some neutrality. It gives you an opportunity to kind of focus in and shorten those scales a little bit, because for some things like provider communication, we know that it's harder to rate that on a 0 to 10, but it's a lot easier to rate it on a 1 to 5, or like in HCAPS 1 to 4. You've got those opportunities for that. And I think sometimes that lessening that focus on, who's in the top box or the top 2 box is kind of helpful, because again, you can see progress. And that's where the beauty is, because net promoter score or a net score, but well, net promoter score in particular, you're really taking your percent of 9s and 10s, you're subtracting your percent of 0 to 6s, and that's your net promoter score. And so you can literally see in your score when you've moved somebody from a 0 to a 7. And that's what's huge. With a top box score, if you move somebody from a 0 to an 8, you don't feel that in your score. You're still just focused on that 9 and 10. And so, and I used to get this feedback too. CMS, HCAPS, they focus a lot on top box. A lot of nurses, a lot of nurse leaders are like, when we're focusing on top box, you're telling me I got to focus on being perfect. And that can be just as detrimental as anything else, right? Like if you're always striving for perfection, you feel like you're never getting there, you're never going to get to 100%. That's tough. That's really tough.
So before we run out to another break, Patty, any other questions you want to ask?
Yeah, I guess so. Many healthcare leaders might be surprised to learn that billing and registration often are considered the necessary evils of healthcare. Actually measuring, impacts on patient loyalty and so forth. How do you help organizations calculate the true cost of a poor patient experience in these areas?
Yeah, it's such an important aspect, because we know, particularly now when we talk about like the evolution of healthcare, um, service failure can drive a person away from your health system. And I think for a long time we really focused a lot on patient retention. How can we keep patients in the system? And like that there's obviously good reason for that, because if you lose a patient, you could be losing millions of dollars of income around that patient. The patient could be losing a long-term healthcare plan, long-term plan around their own personal health. So not even insurance or anything like that, but just there's so many ramifications there. And I think what it's kind of coming down to now, and actually conversations I've had over the last couple of weeks, is how do we really determine, we've focused so much on when we've lost a patient, but how do we start to focus on when we haven't even captured that patient into our system, when we haven't even built enough trust to bring them in and capture them, right? So, so many other organizations are so focused on how do I keep somebody from going to my driving past my location to go to my competition, right? And it kind of goes back to that example, I got a lot of choices. If my kid's sick and I got to get him to urgent care, I got a lot of choices. What's gonna capture that? But also understanding why I picked the way I picked. And so I think there's research opportunities around there. I think there are patients that are interacting with us on our digital front door. I think they're interacting with us by calling us that we're not capturing. And I think there's a lot of valuable data in there that tells us, hey, what fell flat there? Right? If we're not listing at our website to see that I'm going in and trying to, make an appointment with a doctor and I can't find the available appointment because something went wrong in the background or we're not providing enough information, making it hard to find, that's just as important as being able to learn, hey, I had a service failure and I'm not going to come back to this healthcare system. I think we've weighted one more than the other, but I think now there's this hunger, and there's more involvement in how do I capture those folks and get them to drive past the competition to come to me. And that's where that consumer experience is starting to, has started coming into healthcare over the last few years.
Right. We'll be right back.
Vine Medical serves a growing base of more than 800 active hospitals and health systems nationwide. Their best practices are hardwired through technology solutions, proven to help hospitals achieve sustainable top performance. Their well-published results include improving financial performance, physician and staff alignment, patient experience, compliance, and patient safety and quality measures. Learn more at vinemedical.com. That's VYNE medical.com.
Claim Capital is a team of ex-Epic staff focused on preventing denials. Instead of showing what was denied, which is the standard for other solutions available today, Claim Capital pinpoints why claims are denied. By training machine learning models on an organization's claim and remittance data, Claim Capital can identify the causes of denials and recommend changes in EHR build or workflows to prevent them from happening in the future. With a completely HIPAA-compliant infrastructure, no software implementations, and a zero-risk pricing structure, organizations can quickly and safely recover lost revenue.
All right, and we're back. So, Patti, should we jump to the Wilshire Lab?
Sure, we can do that.
I'll jump in with a question.
Okay.
What is your best advice that you've received throughout your patient experience career?
I think it's probably been to try not to get stuck in the way things are and focusing on like the roadblocks, but focusing on like what could be. And really looking beyond the constraints of kind of those lanes you're in. Some of the folks that I've seen do well have been the ones that have kind of gone out and said, you know what, I'm gonna go do this, and we can ask for forgiveness later. But if it's what's right by the patient or what's right by improvement, go do it. And that's usually paid off. Now, of course, always within some confines there. But I think I find myself, we all do sometimes find ourselves in, kind of we can get down in that hole of this is broken and in anything in our life. And so that's kind of gone beyond that, right? Like instead of focusing on it's broken, like, hey, if this is a dead end, then what new direction can we go in? Or what can we do to actively fix it? And that served me well in my career.
Okay, I've got two questions. I want to get these in so I can get answers. The first question is around responses. Is there your sample size and the importance of not overreacting if you don't get enough of a sample size in? a small sample size, but what is the ideal sample size? That's my
Yeah.
first question. And then let me go ahead and give you my second one so you can kind of do both of
Okay.
them. My second one is, registration and billing, they've always been considered, the bookends of the experience.
Mhm.
Bookends of the experience. And nobody ever likes the bookends of the experience. Does Qualtrics, should those be measured the same? Is there a difference in how you measure those versus the nursing experience or the scheduling experience, or do we measure it all the same? I mean, just trying to get your idea, your thoughts on how we measure that, because it just seems like we're always, fighting amongst, what it looks like.
Yeah. Yeah. So the first part of your question is, um, my data science friends would tell you that the rule of 30 is always pretty good, right? Like you're going to stabilize a little bit over 30. My answer to you would be, sometimes you can't focus too much on the scores if you have a low end size, but you can certainly focus on the voice. You can certainly focus on what folks are telling you. And you can be creative in the way you're measuring experiences if you can find like experiences within your organization and look at those scores as a whole. Um, you know, I you never want to make a decision on little two data. Um, and you can still go in there and make a good educated guess, and you can leverage the tool to kind of bring out insights to say like, hey, what's happening or what's happening larger in the organization that may be impacting me. And sometimes you just have to be comfortable within the discomfort of lack of data, right? We have a hard time with that in healthcare, by the way. But we're getting better with that. I think for the other part, measuring the experience across the board, I think from the standpoint of being able to understand that these are interactions with people, you have to build some level of base expectations around that, right? Organizations who have good cultures who are tied close to their values, they do this really well because communication is key no matter where you are. I've heard organizations say like they know that their billing process is difficult. They're really trying to improve it. The ones that like grasp that and understand that, or who have experienced that themselves, they can empathize so well with patients when they're running into those roadblocks. They can especially tell them, like I had a personal experience where, they changed the insurance company said, hey, he has to move to this medication. It's a like medication. And the person who I was talking to, like, that was very nervous for me and my wife, for the care of my son. But the person we were talking to had a lot of empathy around it, talked us through it, explained to us where that process was and what process we had to follow if we felt like it wasn't the right decision. And we hear sometimes organizations say, like, well, we have all these other resources, and why aren't they taking advantage of them? Well, it's a communication piece, right? And so how we're measuring the interaction should be very similar across the board. But there are other metrics that we can bring in that help us also, judge some of that because we can bring in the operational data into anything that where it's available, and we can start to tie to that. That gives us these data science insights that if we do X, then this will happen. If we do this, this will improve. Or when we do this, this many people say things aren't going well. But from a purely PX standpoint, like if we're just listening to our patients and then communicating with them, empathizing with them, being very clear in the expectations and setting them, we can measure that because that's the same experience from a nurse to a patient or a doctor to a patient. Listening, understand, explaining, like it's the same across the board. And even at the bookends, it's very useful. And we know the bookends feel very real, but that's also an ongoing cycle too, right? Those bookends are there for every experience we have, whether it's just a visit to my provider or to go get a test or an inpatient or ED experience. The bookends are the same.
It's a must
They
have.
feel
Yeah.
the same no matter what, right?
Well, we are at time. So this question's for both of you. How do our listeners get in contact if they want to learn more about your guys' experience, learn more about your organizations, or just generally are intrigued to see what else you got going on in your career?
Yeah, absolutely. So I'm easy to find on LinkedIn. I'm on there as Matthew Lauer, MBA, CPXP. I might have that backwards, but I have my credentials in there, so it does make me a little bit easier to find on there. You can also find out more information about Qualtrics at qualtrics.com. But always feel free to link me on LinkedIn, reach out. I love to talk to folks, about Qualtrics, but I love to I talk to a lot of people who are thinking about career changes and career moves or just want to know more about patient experience. I love to connect. I don't know if that came through today, but I love to connect with people. So,
No, we appreciate you being on today with us. I certainly did enjoy the conversation, but thank you, Evan. They can reach out to me via LinkedIn as well, and I am Patti Consolver, and they can also email me at patricia.consolver@ascension.org.
Awesome. Well, are there any final thoughts from either of you before we wrap it fully up?
I think this was a great conversation. I think a lot of people will be interested. Patient experience is a very hot topic.
Yes, absolutely. No, I appreciate you. I appreciate having an opportunity to spend some time with you guys. It went so quick, but it was a great conversation. You've touched on, obviously something that's a passion of mine. So I appreciate the conversation. I appreciate the invitation.
Awesome. Well, thank you, Patti, for co-hosting and introducing me to Matt and getting me linked up. And Matt, thank you for joining. And for listeners, submit questions and we can get them over to Matt and Patti as well that way through our email. From there, that's it for us. Bye-bye.
If you liked today's episode, continue to join Wilshire Wednesdays. You can follow us on LinkedIn or Twitter at Evan_Wilshire, on Facebook at the Wilshire Group, or on Instagram at Wilshire IT Revcast. Remember, if you prefer to watch, come check us out at the Wilshire IT Revcast YouTube channel. If you have an inquiry, want to share your thoughts, or get additional information on today's episode, email us at wilshirepodcast@thewilshiregroup.net. The best way to support this podcast is to review, rate, and subscribe. The Wilshire IT Revcast is hosted, produced, and engineered by Evan Martin. It is executive produced by Gretchen Case, Hank Smither, and Spencer Thielman. The Wilshire Group. Experience you can trust, results you can count on.